record button.
I got it.
Yeah.
Okay. All right, good morning. Can we have everybody else's, can we have everybody muted except for me?
The Patho that wants to make you fall.
If you, yeah, everybody's muted except for you.
Well, they're not muted on my end. I can hear everybody. Okay. That's better. Okay, good morning. We got a lot of stuff to cover today. I'm going to try to do it pretty quickly because everybody has many things to do. Today we were going to talk about update on diabetic emergencies, hyperkalemia, sort of basically some basic science. We of course decided to take out all the Krebs cycle and all those things that you guys love, but we are also going to spend at least, well, it'll probably take us at least 20 minutes or more on the update on the new behavioral health protocol that's in place now, which is a work in progress as we're trying to adjust to the changes in law enforcement's ability to engage with agitated patients. I'm also going to do a little bit of a discussion about the about masking again, because we're rapidly going into a crisis. Now I lost my screen, Mark. This is replaced with a whole bunch of other stuff. So did you lose my screen too? Now I can't hear anything either. Mark, are you on or off?
We can hear you, Lynn.
Okay, but I can't see anything to see what I'm presenting. Are you seeing what I'm presenting?
No, I see. I think we all probably see exactly what you're looking at, and that's the buttons of everybody that's here.
Okay, let me see. Go back in this and add this thing to it. See if I can bring this back up.
10-4, standing by.
Oh, okay, I can see my screen again. Can you see me? Tim, can you see this?
Yes, we can see.
There you go.
Okay, all right. I don't know what happened, but whatever you did, shifted it to something entirely different. Okay, so let's get going with diabetic emergencies and then we can get on to the other stuff. So basically in diabetes mellitus, which means sugar diabetes, carbohydrate utilization is reduced while lipid and protein utilization is enhanced. The real problem when you use lipids and proteins is that you don't get the same calories out of that process because it's an incomplete process. Lipids work best when they are converted to glucose by gluconeogenesis and then broken down through the standard glucose process through insulin. But with diabetes mellitus, it's an incomplete process, and so you end up with acids and decreased production of calories anyway. Now, insulin is a very interesting thing. It's basically catalyst, which increases membrane permeability by affecting facilitated diffusion, and then also it increases glucose phosphorylation, which means that glucose has to have phosphates added to it in order to break it down to get the calories out of it. So that's where you go to ATP, ADP, AMP, etc. Also, insulin increases glycogenesis by when you have excess, when you take in excess sugar, and most of us take in excess proteins, sugars, and fats when we're eating, and we're not utilizing it for energy at that time, and it's stored in the liver in the form of glycogen. Also, when you take in more calories in the forms of carbohydrates than you use, that becomes stored in your body in the form of glycerol. So you have fat synthesis. You take glucose and your body processes it in the liver again to make glycerol, which is stored fats. It also suppresses the counter-regulatory hormones, which are glucagon and epinephrine. Now, when your blood glucose level falls, and for most of us that's falling below 60, and in the case of a true diabetic, if it falls below 80, you begin to release the counter-regulatory hormones, which is glucagon, which causes glycogenolysis, which means that it takes glycogen that's stored in the liver and begins to break and breaks it down into the component parts, which are glucose. So it provides sugar for you. Epinephrine and norepinephrine release, and they primarily enhance the ability to do fat metabolism, and they convert fats into glycogen, and then you get glycogenolysis, which breaks down, which releases the glucose. They also release cortisol, which increases fat metabolism, growth hormone, which basically is a stimulatory hormone which stimulates the other things, glucagon, cortisol, epinephrine, and then it inhibits the release and production of insulin, because insulin would, of course, lower your blood sugar again. Now, two types of diabetes. Type 1 diabetes, body stops producing insulin or produces too little insulin to regulate blood glucose. In type 2, pancreas still secretes insulin, but the body is partially or completely unable to use it. It has insulin, what's known as insulin resistance. Type 1 diabetes, where you have total decrease, maybe to the point of cessation of insulin production. That's 10% of all diabetic patients, or 15 per 100,000, and I calculated that out the other day, which means it's about 67,000 type 1 diabetics in the United States. Early onset, usually in childhood. The youngest I've seen was 1 year, was 1 year of age. Generally speaking, it's 5 or 6. Adolescents, very common. 1.5 more times likely to develop in Caucasians than in American Black or Hispanic patients. All patients, type 1 patients, are insulin dependent. They need to have exogenous produced insulin because they don't produce their own. They are not going to be able to survive with pills, because pills help your pancreas to release and make use of the insulin that you do have. Now, type 1 diabetes problems are increased risk of infections, increased risk of kidney disease, ocular disease, also small vessel diseases, nerve injury from small vessel disease, hypertension, coronary artery disease, and strokes. So the basic is the destruction of the insulin-producing beta cells of the pancreas. Peak onset 11 to 13. Very uncommon. I personally have never seen one. I have never seen a true insulin-dependent diabetic that was over the age of 30. Now, many of your type 2 diabetes, the adult onset, late onset diabetes, will require some insulin, but not at the beginning. Etiology there may be some viral component of this, maybe environmental, and it's more than likely genetic because it is passed on familially. New cases, curiously, usually occur in the fall and the spring. Symptom onset is often very abrupt, and because they're prone to ketoacidosis, the first time they may seek medical attention is when they're in their first episode of ketoacidosis. So we see a number of children, 7 to 13, who come in ketoacidosis, and they're going to be newly diagnosed as diabetic. Classic presentation of diabetes hasn't changed. It's still polydipsia. So they have an increased hypothalamic thirst response because of intracellular dehydration. Here's the basic rule with it. Diabetes, especially as you get to ketoacidosis, essentially this is a dehydrational disease. So they're all water short. Simple process. Increased blood glucose. You've got, once you go above about 180 DL mils per DL, as this very hypertonic glucose-loaded serum goes by the kidney, it is unable to reabsorb the kidney, the glucose that goes through the kidney tubules, and so the urine becomes hyperosmotic because of the glucose, and water follows the sugar, and so you end up having polyuria. You urinate a lot more than you come out. So essentially, you begin dehydrating your cells, and so you get intracellular dehydration. For quite a while, you can maintain your intravascular volume, but then it becomes depleted as well, and you end up urinating out glucose and a lot of water. Now, you get polyphagia, a lot of hunger with that, and they eat a lot because of decreased carbohydrate, fats, and proteins. The cells are starving, and that's interpreted at the hypothalamus as a hunger response. Weight loss due to loss of body fluid and tissue. Fatigue because you're not utilizing your carbohydrates correctly. The fats and proteins are being broken down, and it's inefficient, doesn't produce as much calories per gram, and you get acidotic as well as extreme fatigue. Now, along with this, and I have to mention this at this point, along with this, as you begin to, besides water following glucose, potassium follows glucose. So potassium comes out of the cell into the hypertonic serum and then is excreted via the urine because it also follows sugar into the urine. So the net effect is a total body depletion of potassium. Now, curiously, at some times you will end up getting hyperkalemia of the serum. That's what we're testing when you get hyperkalemia. And so you're going to have a decrease of potassium in this intracellular and an excess of potassium extracellular because of the glucose. So the cells have been depleted, but the hyperkalemia that we see on the EKG and the problems with hyperkalemia, cardiac problems, are because you've got the potassium really belongs inside the cell and not outside the cell. Ultimately, that person is going to be low in potassium, and when you rehydrate them, their potassium levels may go from hyperkalemia to normal kalemia or even hypokalemia. Now, type 2 diabetes, insulin resistant, here's where the vast majority of diabetics lie. And this last count, 34.2 million Americans, 1 in 10 have diabetes, type 2 diabetes. But 88 million American adults, about 1 in 3 are pre-diabetic, meaning that at some times during the day, they will have an elevated blood glucose because they are not utilizing, their insulin, their insulin that they do have is not adequately functioning and not adequately managing their glucose level. Now, this is related to eating as much as anything. It's mostly related to obesity or pre-obesity, lack of activity, genetic factors, but it's becoming more and more common. It's becoming common in adolescence. We see it. And it can be controlled with diet, exercise, and weight loss. You have the same problems with type 2 diabetes that you do with type 1 diabetes, increased risk of infections, kidney disease, ocular disease, nerve injury, hypertension, coronary artery disease, and strokes. Patients frequently take oral medications and insulin. This is a societal thing. Although you can control it with diet, exercise, and weight loss, everybody wants to have a pill. Now, with type 2 diabetes, they may have normal insulin levels and may have normal beta cells, but for a variety of reasons, they utilize their insulin poorly. The usual onset is over 40 years of age. Patients are usually obese or pre-obese. We look now at BMIs above 25, and that's concerning to us. When you get above a BMI of 30, that starts getting, you get to be called obese. And they usually are suffering end-organ complications, which makes even more problem with their with managing or being able to treat their type 2 diabetes. It is a disease of lower socioeconomic and educational status, 3 times more prevalent, probably related to all sorts of things, diet, etc. Now, getting back to diabetes in general, here's the basic pathology of diabetes mellitus. Although we talk about the insulin, we talk about sugar. When you get into emergencies, we're talking about chronic and acute dehydration at the cellular level and osmotic diuresis due to the urinary sugars, and then acidosis. So an increase in keto acids these are like acetone, and that's why classically we would tell you, if there's a fruity smell about the patient, that this, you think of diabetes, think of ketosis at that point. You can get ketosis by starvation ketosis too. So someone who's been sick for a while and not eating, and so they're breaking down fats and protein to provide energy, they may be ketotic as well, even though their blood glucose is normal. And then there's hyponatremia, because as you excrete the keto acids through urine, sodium follows these because you make salts. And so they become hyponatremic, which affects your cellular function and your cardiac function as well. So end-order complications of all forms of diabetes is accelerated atherosclerosis. So think coronary disease, think strokes, microvascular disease, capillary, so kidney disease, the number one cause of kidney disease in the United States, along with, and the number one cause of the reason to have kidney failure and get kidney transplants is diabetes. Diabetic neuropathy, so pain, numbness, paralysis of muscle groups, nerve groups, autonomic dysfunction, failure to be able to regulate your temperature. So people with diabetes have much more risk for hyperthermia. It's something we're going to have to consider this week. Demyelinating diseases, so that they seem to be almost like they've got muscular dystrophy or MS. Abnormalities of Schwann cells. Schwann cells are sort of the white matter cells that in the brain. So now, okay, there's a couple of diabetic related emergencies. Now, a true emergency is hypoglycemia, and hypoglycemia is a fall in blood glucose that elicits symptoms of glucose deprivation in the central nervous system. Now, remember, when you drop your glucose, the insulin counter-regulatory hormones are released, and that included epinephrine and growth hormone and cortisol and etc. So, but the symptoms that we're most familiar with severe hypoglycemia are diaphoresis, pallor, tremulousness, tachycardia, palpitations. Those are the symptoms of adrenergic. So that's epinephrine. Along with that, you often get visual disturbances, mental confusion, weakness. Now, there's some gradual things that occur due to the other counter-regulatory things: fatigue, confusion, headache, which is a new thing. I think it's supposed to be headache, memory loss, seizures, and coma. So, why do these things occur? Why do you get the changes in the brain, the mental confusion, memory loss, seizures, coma, sometimes some extreme agitation? It's because there are two systems in the body that do not use insulin. One is the red blood cell, and the other is the brain. For some reason, your brain only depends. It has been designed to use to require a slow diffusion of glucose which requires an adequate serum level of glucose. So, and the sort of what I was taught is the ratio is about 2 to 3. So if you have a 90 blood glucose, you have essentially a 60 brain glucose, and that's adequate to maintain total brain function. However, if you have a blood glucose of 60, that means you only have a blood glucose of 40, or brain glucose of 40, and that's where you're going to start getting real symptoms. If you have a blood glucose of 40, then you only have a brain glucose of 25. So that's where you start getting into the seizures, coma, etc. So pre-hospital management of hypoglycemia, we've changed, but for 10 years now, and I noticed looking at other things around the state is that they also are using D10 is to determine the blood glucose, and in an adult, if it's less than 60 or less, or in a known diabetic patient, if it's less than 80, if the patient can protect their own weight or airway, give them some oral glucose. If a patient is unable to protect their own airway because of their confusion, semi-comatose state, whatever, then dextrose 10 grams, which is 100 cc's of the D10, and you can repeat that by checking the glucose every 5 minutes or so, and checking the symptoms of the patient. And if they're improving, you don't need to give any, but you can repeat glucose up to a total of, like we used to, the 25 grams. Several years ago, we presented the scientific reason for not doing this, but the basic, or for not continuing to give D25 or D50 rather at 25 grams single push, is because that wasn't really scientifically calculated out. And what that does for literally everybody is raise your blood glucose so high that it entirely throws off the management of that patient for the next couple of days. And so we get a lot of bounce backs who then have another episode of hypoglycemia after this one if they were left at home. And of course, we know we don't have to transport diabetics who wake up from hypoglycemia who are normal and able to eat and able to function, and they're competent to sign their own release. But we do transport them if they're also on an oral agent, because that means there's something significantly wrong with their glucose management at that point, and they're gonna definitely have another bounce back. Check your blood glucose after 5 minutes. Repeat if blood sugar is low. If you can't give an IV, glucagon, 1 milligram or 1 unit IM for the patient. Now, pediatric wise, for infants less than 10 with the blood glucose less than 40, or children 10 to 35 kilogram with a blood glucose less than 60, give D10, and we made it so you don't have to calculate out the 0.1 milligram per kilo. Give 1 mil per kilo, which is 0.1 gram. 1 mil per kilo, not to exceed ultimately a total of 225 grams total, but you would give it 1 milligram by kilo. So if it's a 10 kilo kid, you give them 10 mils of the D10, check their blood glucose again, and if you need to, give them more. Now, dose of glucagon for a child is 0.02 milligram per kilo. to a max of 1 milligram adult dose. And that can be given, glucagon can be given IV, but if the argument is you can't get an IV going, so that's when you would use it. That's the only time you should use the glucagon, is if you can't get the IV. So I've seen some reports that you can give it intranasal as well, if you had to. I'm not sure why you would not do it IM, which we know works. Now on the extremes of this, now you've got endocrine emergencies.
I'll tell you later.
Okay, endocrine emergencies, ketoacidosis, diabetic ketoacidosis. This is an absolute relative deficiency of insulin and increase in insulin counter-regulatory hormones, epi, cortisol, glucagon growth hormone, and still the blood glucose keeps rising, and because you're not intracellularly, you're unable to use the glucose, so it is not going intracellularly except by slow, non-facilitated diffusion. Hepatic glucose production, so glycogen is broken down to glucose, fats are mobilized and going through the glycogenolysis process and then broken down to glucagon or to glucose. Peripheral glucose usage decreases, ketogenesis is stimulated because fats are now utilized directly for energy, and you develop ketone bodies. Clinical manifestations, polyuria, and severe dehydration. Sodium, phosphorus, magnesium deficits, and they may have a profound total body hypokalemia. However, at some stages, you may find evidence of serum hyperkalemia, which you will probably want to treat. Now, signs, Kussmaul respirations. Why are they breathing deeply and rapidly? Because they're trying to blow off carbon dioxide to decrease their acidosis. Orthostasis. Well, why? Well, that's why they don't get up off the. They will pass out if you try to walk sometimes if you try to walk them to the gurney. So when you get them from a laying down position to a sitting out position, they may get very dizzy, may even pass out. Why? Because they're dehydrated. CNS depression because of the acidosis, because of the changes in their pH, their changes in their electrolytes, and also because, frankly, they're sort of being bathed in a supersaturated solution, serum solution of glucose. They don't need that much glucose in the brain. Remember, the brain, their cells get sort of glucose loaded. Anorexia, nausea, abdominal pain, thirst, polyuria. So how do you treat them? Altered mental status protocol. And you'll get a glucose that says very high. We don't test for ketosis, although that's probably coming sometime in the future. And I would look at if their CO2, PaCO2 is, or SpCO2 is low, I would make that assumption that they're acidotic. And the fluid challenge, so simple, and the fluid challenge for an adult is 500 to 1,000 cc's by the time you get them to the hospital. Now, there is another thing out there called the alcoholic ketoacidosis, don't see tremendous amount of it, but if you have an acute cessation of chronic alcohol abuse or binge drinking, and then they stop drinking for, at the end of that binge, it's associated usually with anorexia and also with dehydration. The clinical presentation is nausea, vomiting, abdominal pain, shortness of breath, and they're ketotic. They will be hyperventilating and trying to blow off their CO2, but they won't have this high level of glucose. As a matter of fact, their glucose is often perfectly normal. Alcohol can be, in and of itself, a little hypoglycemic. Treatment is fluid resuscitation and actually the administration of glucose, because that increases insulin production, and the insulin begins to it stops the fat utilization by utilizing the glucose. Now, Mark throws this in. He always likes this. It probably explains why people who have severe hangovers like to eat high carbohydrate loaded things, because it does help to reduce that ketosis. All right, couple of complications. So complication of diabetes, hyperkalemia, I want to talk about that. We see a lot of this, and a lot of it's in association with chronic kidney disease, which I said is also often because of diabetes. There are a lot of other causes of hyperkalemia, but let's just stick with this one in relationship to diabetes and think about renal disease as well. So hyperkalemia is a defect in the excretion of, so if you go into hyperglycemia, but your kidneys are also injured, chronic kidney disease, even though you're excreting a lot of glucose in your urine, you can't excrete the potassium. So there's a cellular shift. So potassium has followed glucose out of the cell into the blood, into the serum, and you have now hyperkalemia of the serum, and then you can't excrete it renally. So this gets worse and worse. Remember the basic rule, potassium always follows glucose. So if you can get glucose to go back into, if you can facilitate glucose to go into the cell, you can move potassium in there, or other things to move potassium into the cell. So clinical presentation classically starts out at about serum, normal serum potassium is 4.5 to 5, roughly, maybe 5.5. And at 6, you start getting peak T waves. The P wave also flattens. At a level of 7, the QRS widens. At a level of 9, you have deep S waves, and the S and T waves begin to merge together. And at greater than 10, it looks idioventricular, usually, maybe a sine wave kind of look. So here is hyperkalemia at a lower level. You get dysfunctional weakness, paresthesias, areflexia means you start to lose your reflexes, descending paralysis, and nausea, vomiting, and diarrhea is frequently. That's when you have vomiting and diarrhea concomitantly, that in and of itself lowers your potassium. That may be the attempt by the body to get rid of potassium. Now, at a level, this one is about a level of 7, and you can see the changes. You still have what I would call peak T waves, not in every lead, but you begin to widen the QRS, and you can't find not only did the P wave flatten, it's sort of gone. You could make an argument that this is maybe atrial fibrillation because you can't find the P wave, but then you see the rhythm strip V1 down there. It's perfectly regular, so it's not AFib. This is a level of 8, so it didn't change too much, and those are beginning to look kind of worrisome, real worrisome, and it's also getting to be kind of bradycardic. So it's essentially idioventricular or junctional, and it's beginning to get worrisome, very worrisome. Now here is 8.7. Kind of same thing, but this one is not, these are all different patients. So you've got real peak T waves that maintained in this one, even though, and you've got the other findings. 8.8, same thing, is beginning to get, that person is probably not perfusing very well. Now, how do we treat hyperkalemia? Simple, not simple, but 3 phases. You first try to stabilize the cardiac membrane, and then you try to shift potassium intracellular, and then we try to excrete potassium. We at EMS level, we can't do much about excreting potassium, frankly. So what we do, so to stabilize that membrane, calcium, and we've chosen gluconate. You can use chloride if we didn't have the gluconate. Chloride has some real downsides, and it's so hypertonic that if you extravasate, you get some pretty nasty skin necroses and things. It's something we'd like to avoid. Albuterol shifts potassium into the cell. Sodium bicarbonate, by alkalinizing the serum, shifts potassium into the cell as well. So our specific pre-hospital protocol calls for universal patient care protocol, established in IV. The fluid of choice might be, although it's almost theoretical, might be a balanced salt solution and not lactated ringers. The thing with the lactate, it may affect your calcium gluconate may react with the lactate, but it's probably not of significant concern. There's such a little bit of lactate in that, so I wouldn't hold my breath on that one. But establish an IV fluid, and generally speaking, with hyperkalemia and it's particularly if it's diabetic ketoacidosis associated with it, they're going to be fluid short, so they're going to need fluid. Then I would give them calcium gluconate, and our new orders call for 3 amps, which is 30 mils, slow IV, flush the tubing between, and then give sodium bicarbonate. Remember, we don't give calcium and bicarbonate because you get calcium bicarbonate, which is rocks, and we don't like to have that precipitant inside the patient. So flush in between, give sodium bicarbonate to shift. Will shift this into the cell, and give that albuterol by a continuous med neb. And by continuous, I mean you can give up to 20 milligrams by the time you get to the hospital. Now, albuterol shifts potassium by 0.5 on almost every human being. Will drop that amount. And that may be enough to make a main difference. Follow your other protocols for dysrhythmias. Keep the patient on a monitor. You should see some change, and you may want to do a 12 lead each time. You should see some changes in your monitor, in your 12 lead with the T waves and the QRS complexes, and maybe even the P waves. I think that the 30 mils of calcium gluconate will be enough for most of our patients. That unless you're transporting a huge long time, like from the far ends of the county, that should be adequate. You don't need to repeat that. You might want to repeat if the patient's 12 lead begins to deteriorate again, I would, you could certainly give another dose of bicarbonate. I don't think most rigs will have any more than 3 or 4 amps of calcium gluconate. Okay, any questions up to that point, or anything in the chat, Mark, or anything I should be aware of? Okay. Let me talk about the new behavioral protocols, and I have to give you a little bit of a background on why we have to do this. You've probably heard a lot of talk about what the about police response or police non-responding to usual being dispatched for behavioral health things. And one of the common examples is a person maybe asleep in the car. They're not going to that anymore. A person asleep on a or laying on the park bench or sleeping or dead or whatever in a park. They're not going on those either. This is all in reaction to a whole bunch of legislative things that happened this year in the Washington State Legislature. The main bill is House Bill 1310, which in and of itself looks pretty benign, which requires law enforcement to use the least amount of force necessary to mitigate circumstances. Now, but specifically says that law enforcement may use force to, if a crime has been committed, or if a person, including the person who the force might be applied against, is at risk of death or severe bodily harm. Now, that sounds pretty permissive to me. However, they established, they did not establish, this law went into effect the minute the governor signed it, but without, but with the specific notation that 2 different commissions would be working on the rules, and they have a year to come up with the rules. So basically, this is all thrown out there for each law enforcement agency to have its attorneys and administrative bodies tell them what they should or shouldn't do and how much they've been at risk. But then this is complicated by the other list that I've got up here. House Bill 1054, which is a police tactics bill, which regulates what kinds of things they can do. For example, says they can't use neck restraints or chokeholds. Well, that makes perfectly good sense. They can't use military equipment, although that's not further defined, because the SWAT teams go out and they have basically a assault rifle, but it's not defined as to whether that's okay or not. It tells them when they can use and when they can't use tear gas. They can't have no-knock investigations, no-knock entries. Then House Bill 1267 established a new office at the governor's level, an Office of Independent Investigations. And of course, that hasn't been worked out as to exactly what they can and can't do. Senate Bill 5051 broadens the list of offenses that could be charged against a police officer. Senate Bill 5056 requires that if you're an officer and you see another officer violating one of these rules, you have to turn them in, or if it ultimately comes to light that you will also be charged with abetting the other officer. So it's a sort of a snitch rule. Senate Bill 5259 requires data collection on all injuries and deaths that occur in police custody. So the police are quite anxious about a number of things, particularly the fact that no one has really established the rules yet, and yet they're expected to function under. So many of them have many police agencies have decided they would significantly reduce their response to behavioral health emergencies. Now, in one sense, I'm very much in favor of decriminalizing behavioral health. But at the same time, I realize that, unfortunately, EMS gets called into these situations, and we have depended for a long time on law enforcement to assist us, and we're sometimes called by law enforcement to assist them, and it puts us in a position of being at least vulnerable to the more aggressive and uncontrolled patients. So we have established a couple, and with the ground level here, the basic thing that EMS has to understand is that you may or may not get any response whatsoever from police. And you may be dispatched to situations where you come up and there's a person in a car. You don't know if they're unconscious, sleeping, dead. You don't know if they have a weapon in there or not, and and you're to exercise extreme caution with that. So establishing a scene safety, remember, that's one of the first things you're taught in EMT school is scene safety. So assess, assure scene safety. We're going to all use a come to us approach. If the individual is in a building or an enclosed area like a car, ask them to come out. And how do you ask them to do it? Well, sometimes you have to get in touch with them by phone. Sometimes you can use the PA system on the rig to ask them to step out of the car, etc. Approach the individual in a calm, slow, reassuring, and honest manner. One person should make that direct contact. Multiple people may increase, especially in a behavioral health, may increase the agitation of that patient. They don't often like uniforms, which is one of the reasons why police sometimes agitate the scene. Protect individual bystanders and rescuers yourself from injury. And we have an agitated patient management protocol. That's a separate thing. Get history, physical, mental exam status. If it's safe to do that examination, assess and treat any medical conditions per your protocol. So if they're hypoglycemic, which is one of the causes, sure. If they're and within our new agitated patient management protocol, if they are slightly if they're amenable to taking an oral medication, we have an oral medication to help to reduce their agitation if it's appropriate. Think about alternative mental health facility protocol. I noticed that we missed something in this one when I read this morning again. Contact receiving facility and advise them to have an EMS patient for consideration and find out if they can accept the patient. We have the Rainier Springs list there, but we have to list the county's acute mental health center as well. That will be corrected. Contact medical control for confirmation of assessment findings and whether it's appropriate to transport that patient to a non-medical facility. And we have inclusion criteria checklists and all that. and document that and provide that to the receiving facility. If it's safe, all individuals should be assessed by EMS, regardless of whether you're going to transport them or not. Now, we have an adult mobile crisis intervention team. I talked to them yesterday about just to inform them of a patient that might be a problem. They can respond to any call from EMS or law enforcement for consultation or on-site visit. They will take, as a rule, in the urban and close in suburban portions of Clark County, they will take about 20 minutes to get to you, but they can be called out to help evaluate a patient. They have right now they have about a 55 to 60% diversion rate, which means that at least 60% of the patients do not end up being transported or do not end up going to the emergency department. They're able to manage this situation. Now, so they're a really good resource to follow. And so the number is there. All you do is call, identify yourself, ask for the AMCI, adult mobile crisis intervention. There is a pediatric team as well, but they're not that we'll have to put. We're still negotiating with them as to whether they're how available they're going to be, and that sometimes is dispatched directly from CRESA. Now, red flags that this might not be a psychiatric or so a medical condition. If they have waxing and waning level of consciousness, that's probably drug or it's probably a drug issue. Abnormal vital signs. Remember, some of your more unusual acting patients are septic. Just recently, we had a combination of the above. A person had possibly seized, was hot, so was thought to be septic, had nuchal rigidity, turned out to have meningococcal meningitis, and was COVID positive. So he had a triumvirate or a trifecta. And had also just done a bunch of methamphetamine for fun. Also dilated and or pinpoint pupils, obviously drug considerations. First psychotic episode over the age of 30. That's unusual. Usually they have a history of you develop psychotic symptoms in your teenage years or early 20s. So it's unusual to have your first psychosis being over the age of 30. So once again, it's thought to be, likelihood to be drugs or medical issues. Acute onset over hours or days. So the fastest onset usually is related to substance abuse. Now, if it's a combination, because about half of our patients will, especially half of them in the right now in the homeless category, are probably dual diagnoses, and they're psychotic patients, and then they have a underlying psychosis and are not taking their medications, and then they use drugs as well, particularly methamphetamine. Psychiatric signs and symptoms: mood disorders, depression, extreme mania. The person that I talked to AMCI about yesterday was extremely manic. Suicidal ideation is a psychiatric sign. Extreme anxiety, thought disorders, hallucinations, pressured speech, racing thoughts, grandiose paranoid ideation. once again, mania and delusions. Medical illnesses that you have to consider are hypoglycemia, hypoxia, stroke, head injury, CNS infection. Don't assume the patient's condition is purely psychiatric. Now, in the management of the aggressive or violent patient, law enforcement will intervene at this time only when an individual poses a threat to others or themselves, or has brought harm to others, or has committed a criminal offense. They will focus on the least force necessary to secure the situation. They may elect to disengage. EMS responders need to treat these encounters with understanding that their and other responders' personal safety is paramount. Protect yourself, protect your partners. You cannot always rely on law enforcement backup. Use any and all means necessary to de-escalate the situation. If the restraint is necessary and safe to do so, follow the agitated patient management protocol. If at any time the individual becomes aggressive or violent and you or your other responders' safety is at risk, remove yourself and fellow EMS fire responders from the scene. Notify law enforcement via CRESA that the individual is violent and it's unsafe to continue evaluation and treatment. Request law enforcement assistance. If none is forthcoming, then your safety is paramount and you can leave the scene. Now, this in an unsecured scene, if law enforcement does not respond or will not engage, contact your supervisor or the battalion chief. Request additional resources. A two-person crew will not attempt to manage incidents where safety is in doubt. Supervisor will review, confirm risk assessment, and this will guide the further actions. If not already done, request the phone number from dispatch to call and ask the responding person to come outside or meet EMS personnel at a location that provides a greater margin of safety. Any contact with that individual will be documented. Transport patient only if safe to do so. If the supervisor, BC, identifies you may not safely enter or remain on the scene or safely contact the individual, the supervisor, BC, will attempt to update the reporting party. Contact with the reporting party will be attempted prior to leaving the scene. If no patient contact can be attempted, CRESA will be notified upon implementation of the decision to leave the scene and terminate the call. It is not necessary to notify medical control of the intent to leave the situation because you're not telling them that you're asking for concurrence to get to leave a patient under an informed consent. Any response that is terminated for crew safety shall be reported to the EMS supervisor or EMS chief captain with a copy of the narrative and behavioral emergency checklist, which is coming in the next couple of slides. EMS chief captain supervisor will forward these to my office for review. We need to keep documentation of all this if we're going to be negotiating with police any further. Here's your documentation requirements. In all cases of non-compliance with treatment and care, a complete and detailed health record is written by the lead EMS provider. Minimal documentation includes disposition, patient review, the disposition, patient refuse service. Include the following elements: descriptive overview of the physical characteristics of the scene, a complete description of the danger or safety elements, list and describe the measures used to attempt to engage the patient, describe, list measures attempt to create safety, describe the reasons why safety could not be established, describe the specifics of the exposure to violence or threat of violence to EMS personnel, and whenever possible, include specific quotes from the individual. So, and specific quotes would include the more scatological things like "get the fuck off me." Specify that law enforcement was requested to respond. Document that law enforcement did not respond or responded and chose not to engage if medical control was contacted. And the reason you would contact medical control is to ask them about whether or not they would talk to the patient, if the patient is willing, whether or not whether they could talk to the officer, or whether they would recommend any change in medications or any change in approach. You are not asking them for permission to leave the violent patient for whom you cannot safely approach. That's in this protocol, so that is already covered by your protocol. When lack of capacity is identified, lack of capacity means that the patient cannot make a choice, cannot make a informed consent, and that means that if the patient is clearly psychotic, clearly intoxicated, clearly under the influence of drugs, and cannot make an informed consent, or clearly has had a head injury and cannot make an informed consent, that is what we mean by lack of capacity. Now, that's a lot of stuff, so we tried to put this into a format that you could follow a little easier. And many of us don't like to use flow sheets, but flow sheets work out okay when you're in a hurry, because you can't read all that verbiage that I just said and digest it. Well, if you're waiting for law enforcement to show up or not show up, I guess you could, but I don't want you to do that. Now, does the individual meet decision-making capacity? If they're of capacity, yes, then it's okay to obtain a patient refusal of care. So if he's agitated and says, "I am not going with you," and you say, "What's going on?" You find out that he is just an angry man and he has no medical reason, or even if he is a perfect capacity and he's refusing everything, and you advise him under your normal refusal of care procedure, that's fine. We don't like that, and in that case, you might talk to medical control and see if they'll talk to him and say, "Yeah, you really need to come in because you have this." North Country had a case not dissimilar to this a little bit ago. If they do not have decision-making capacity, is law enforcement present? Should be present there. I said no. Or if yes, then is law enforcement willing to restrain and place involuntary hold? Yes. And transport with 4-point restraints and appropriate medication if required. Then, now, if law enforcement is not willing to place on involuntary hold, then you go into this other one. And so the no's and this law enforcement not present, request them. If no response, then you end up in the same box. EMS attempts to establish rapport, engage with an individual, etc., etc. Request the crisis team if the patient continues to be non-compliant. A lot of times they will be very compliant, but when you transport them with, transport with a 4-point soft restraint. Don't take any chances. Now, does EMS feel safe to restrain this patient on their own? So there's a lot of difference between your approach to a 85-year-old lady who's agitated and striking out and has a fever or doesn't have a fever, and you think she might be either demented psychotic, or more than likely, in this case, the ones we see more than likely are septic. We can probably restrain an 85-year-old lady safely and without too much trouble. Now, the 350-pound ex-football player who's whacked out on drugs and maybe psychotic to boot is not going to be easily restrained by any of us. So there's a difference in that. Now, if you do not feel safe, then you go to contact the supervisor and explain the situation and gain concurrence to exit the scene. And you advise dispatch of this, etc. Now, the AMCI, sometimes the AMCIs it would be worthwhile to call them at that point, if you hadn't already called them, and advise them of the situation and that you left the patient at home or at the scene. They will attempt to contact the patient then or the next morning, and sometimes in cases of possible where you're not sure if someone has taken an overdose and they're locked themselves in the house and you can't get in and the police won't go in, you may have to, I mean, this would be an appropriate referral to AMCI, who can follow up. We have a little checkoff form here that is going to be available to all crews, and at the end of the, along with filing your medical record, this can be scanned into the record as well. So this is your behavioral checklist, and it has a list of risk assessment. Is the subject harming or threatening to harm people, or is the subject threatening to harm themselves with a weapon? Are there bystanders that appear to present a threat to the subject or to responders? That happens. Are there risk factors that are present that present an unusual threat to the health and safety of responders? It says stage and do not enter if any of the above are present. If contact is made, does the subject meet decision-making capacity? Yes. Then obtain patient refusal, an AMA. If no, they do not have decision-making capacity, or you're unable to establish that, is law enforcement present? Yes. Is law enforcement willing to restrain? Yes. Transport following behavioral health protocol. If no, then you go into the big red section below, which goes through all that we talked about, but this is a simple checkoff form, so you don't have to memorize this. You don't have to always keep referring. So contact your supervisor, BAT chief, contact adult mobile crisis. Whenever feasible, communicate with a law enforcement officer. When appropriate, request a phone number from dispatch to have the subject come out. If the subject contact is attempted, consider requesting a contact timer from CRESA, which is usually a 3 to 5 minute interview, so they can check with you to make sure that you haven't become part of the problem yourself, i.e. that the subject hasn't taken you hostage. Document all resources contacted, threats encountered, etc., etc. And that will be documented in your IR. If the supervisor identifies that you may not safely enter, then you can disengage. So, and by this, and we don't like to do that, but I do not want anyone hurt. Here's a little, here's some documentation, PCR documentation things, descriptive review of physical characteristics and some examples. So this will refer to this when you're writing the narrative. And then at the very bottom is the signs of agitation, threatening behavioral checklist, which everything including display or threat of a weapon, clenched fist, wild staring eyes. That's kind of a threatening gestures, threatening posture, gritted teeth, bulging neck veins, reddened face, abstract speech, paranoia, mood swings, rapid mood swing, unusual behavior, increased sensitivity to stimuli. So a lot of stuff. We're asking you to do more documentation than usual. We're going to be reviewing these and keeping a list of encounters and attempt to deal with law enforcement. I'm discussing hopefully this week with Vancouver Police. They do have what's called a co-responder team, which is a DCR, mental health professional, and a police officer who will go to the scene where, and they can be requested by other police officers or by, for that matter, we think by EMS, but we're going to have to check on that. Usually the police officer tries to assume a very minimized presence and let the DCR discuss with the patient, with the person, what the issues are, etc. But that's for the safety of the DCR. So it's an underutilized thing. So I'm trying to see if we can negotiate utilizing that a little bit more. So I have now reached the end of this. The only thing I know there's going to be questions about this. This has gone out to all of the EMS supervisors for all agencies. This is a work in progress. We're trying to define this and to make it work for us. This is something we hadn't truly anticipated as well as we might have, because it was kind of sneaked on us too. So the only other thing I'm wanting to talk about today, I had public health contact me, asked me if they could have a little bit of time. I said, well, we really don't have any time today, but they want to remind you that we are not out of COVID yet. Matter of fact, we're deeply into it. Clark County Hospital's ERs are just about overwhelmed at this point. At one point, Legacy yesterday had 106 patients in the waiting room, and remember that's a 32 bed ER. So I had 106 patients who were waiting to be seen, and the only ones they're able to take in are the ones that come in by ambulances, and ambulances being offloaded at about 30 minutes now versus our usual 10-minute offload time. And the Portland hospitals are being overwhelmed as well. This is mostly the Delta variant COVID that is causing much of our increase. The hospitals have got more people in the hospital with COVID now and in the ICUs with COVID than they did during any of the peaks in the past. Now actual infectivity rate is not as great as it was in the past, but the ones who are being infected get very, very, very sick. So we're going to have to look at increase, as much as we hate to do that, we're going to have to look at increasing our masking, both when you're out with the public. I'm going to recommend that you go back to all patients, you assume that they've got COVID, and wear at least an N95. I think we're going to have to discuss going back to masking in quarters and masking in your rigs anytime there are any unvaccinated persons that are part of your crews, part of your agency. There's in your quarters at that time, or partners in your rigs. I think AMR has already gone to masking in the rig, at least with a surgical mask. So this is not pretty. This is another reason that people should, encourage their co-employees to get vaccinated. You may or may not know that Peace Health is now mandating vaccination for all healthcare providers. The mandate is they're giving them until the end of August to start getting the vaccinations. They're already short shifted, so I'm not sure how they're going to manage that. But at any rate, I know at least one agency in town in Clark County has mandated their personnel to be vaccinated. Unless there's a medical reason to not be vaccinated. Anyway, does anybody have any questions they'd like to throw out right now? I haven't been able, of course, I haven't looked at the chat during this time period. All right, you can send me emails if you have questions. I would ask you to send it to whitwer@clarkmpd.org. That way I won't get spammed with all. This is our MPD. Our MPD mailbox, so that we don't get all the spam that everybody gets. And I'll try to respond to you.